Hello, and thank you for watching a brief presentation of my applied research project titled The Epidemiology of Shoulder Dislocations, presenting to emergency departments in the United States from 2007 to 2020. I'm Rebecca Rodriguez, a doctoral candidate at A.T. Still University, and my advisor for this project was Dr. Kenny Lamb. I decided to focus on shoulder instability because I discovered that the shoulder is a highly mobile joint but lacks stability. This high degree of mobility contributes to several movements that are required for our activities of daily living and also allow us to complete several high intensity athletic movements such as throwing, reaching, and hitting. However, this high degree of mobility compromises stability. In fact, the shoulder is the most commonly dislocated joint that is treated in the emergency department. And risk factors for this injury include male sex, young age, in the teenage years to young adulthood, and participation in sports, as well as occupations that require physical labor. The typical management for this injury is immediate reduction of the dislocation. This needs to be done as soon as possible after the injury occurs to prevent any complications that are related to a delayed reduction, such as neurovascular compromise, muscle spasm, and swelling, which can lead to permanent damage but also make the joint reduction much more difficult. This is typically performed in the emergency department by a physician. However, other healthcare providers, such as an athletic trainer who has special training in this area, may perform the reduction as well under the supervision of a physician. Long-term treatment goals include preventing recurrence of the injury. Recurrence rates are extremely high, and so that is the main goal of providers treating this. Typically, the long-term treatment approach is either conservative, meaning the patient is in a sling for several weeks and then completes a progressive rehab plan to return to their normal activities, or a surgical approach, which can increase stability of the shoulder joint and also correct any associated injuries that might have occurred with the joint dislocation, such as a soft tissue injury. The conservative approach used to be the standard of care for a primary shoulder dislocation. However, now surgery is being recommended as the primary approach, especially if the person meets the high risk factors for recurrent dislocations. Poor initial and long-term management can lead to pain, dysfunction, and decreased quality of life. So it's important as healthcare providers that we prevent this injury before it ever occurs to allow our patients to have better quality of life. Some previous research performed on this topic was done by Zakili and Owens. They published their work in 2010, and they looked at the epidemiology of shoulder dislocations in the United States from 2002 to 2006. Their key findings included males having higher rates of dislocations than females, which aligns with current research on the topic. And they also found that sports or recreational involvement were the leading mechanisms of injury for shoulder dislocation. After this study, which again was published in 2010, no other studies have been identified to update these findings at the time of my initial project. So the purpose of my study was to provide an updated epidemiological report by utilizing the NICE database to identify characteristics of patients with shoulder dislocations who reported to the emergency department between 2007 to 2020. I utilize a retrospective study design that used the NICE database, which I will speak more about in a moment, to examine epidemiology of all shoulder dislocations that presented to the emergency department from January 1st, 2007 to December 31st, 2020. The National Electronic Injury Surveillance System, or NEISS, is a publicly available database with de-identified patient data. This database utilizes information from 100 hospitals across the United States, and the requirements for inclusion are that the emergency department has at least 6 beds and is open 24 hours per day. The information is entered into the database daily by trained coders who get the information from the participating hospitals, and this database is considered a representative sample so that population estimates can be calculated based off of the data. This has been utilized in the past for other sports injury-related epidemiological reports, including Coronado et al. In 2015, who looked at trends in sport-related traumatic brain injuries, and Durand and colleagues in 2019, who looked at upper extremity injuries in soccer players. We built our query in the NEISS database in September of 2021. There is an option to include several different patient variables, so we selected to include patient age, sex, race, the year of the injury, disposition, location of injury, as well as the narrative description of the injury. This was downloaded into several Excel documents, which were then merged into a single document for analysis. The cases were then manually reviewed in the narrative section of the description of the injury to identify exclusions, such as injuries that were not shoulder dislocations. Common ones that we found were rotator cuff injuries, acromioclavicular joint injuries, and sternoclavicular joint injuries. However, we were solely looking at glenohumeral joint dislocations. We also extracted various injury characteristics, including mechanism of injury, directionality, and laterality of the dislocation, and then finally categorized any sport-related dislocations into sport categories. Statistical analysis was performed using SPSS software to summarize counts, percentages, and rates. The incidence rate data was based on the U.S. Census available data from 2007 to 2019 because the 2020 data was not available at the time of analysis. Now I'd like to go over the key results from this study. So first of all, patient demographics. I understand this is a very busy slide, so I've highlighted the most important features. Males are disproportionately impacted by shoulder dislocations compared to female patients. You can see the huge disparity between the two sexes in the top right corner. Next, the common ages in which shoulder dislocations occur is 10 to 29 years old, and you'll notice these numbers are significantly higher than the rest of the 10-year age groups. And finally, the disposition. The vast majority of patients are treated and released. Hopefully, they are released with a referral to a specialist to have continued care. The next key finding was the mechanism of injury for shoulder dislocations divided by sex. However, first, I want to draw your attention to the lower right-hand corner. Our total number of cases for analysis was 26,203. A total of 899 cases were excluded before a statistical analysis due to alternate or unclear diagnoses. The most common mechanism of injury leading to shoulder dislocations in males were sport-related or recreational involvement for 10,984 cases, or 58.7%. The leading mechanism of injury for females was a traumatic fall, with about half of all injuries to female patients. We also performed a sub-analysis of the common sports and recreational activities that lead to shoulder dislocations. For males, the leading sports are basketball and football, and females were basketball and general exercise, which were activities like a push-up or a pull-up or another exercise that might be performed in a fitness center setting. This graph shows the incidence rates from 2007 to 2019 based on US Census data. The key takeaway from this is that incidence rates remained steady over time with no significant increases or decreases and an average incident rate of 0.58 per 100,000. This figure demonstrates incidence rates as viewed by age and sex. Males are seen in the orange line and females are the blue line. The most interesting thing about this figure is the large peak for male patients at ages 15 to 19, and then they continue to have high rates all the way up until the age of 29, where the rates start to become more comparable to female patients. The females have a small peak there at the 15 to 19 age range, and then once again at 85 and older. The most important and significant key finding from this research was that there was no significant change over time compared to the previous research that I mentioned earlier by Zekili and Owens. This indicates that we need more effective prevention strategies because there has not been significant change and decrease in the rate of shoulder dislocations over the past 19 years. The key similarities between this study and the previous work by Zekili and Owens were patient sex, age, mechanism of injury, as well as sports that lead to shoulder dislocation. Again, males are disproportionately impacted by shoulder dislocations compared to females. In this sample, the male patients made up 71.4% of the total sample, and females were 28.6%. This aligns with previous research that also puts males at much higher risk for shoulder dislocation. The ages were also very similar from my research to the previous research on this topic, with the highest rates occurring in the 20 to 29 year decade, but when split into 5-year age groups, the highest rates occurred from ages 15 to 19. This aligns with previous research performed by Hume and colleagues in 2014, as well as Smith et al. In 2015, which indicates that the ages 10 to 20 are the highest risk for primary shoulder dislocation, and age under 30 years old is the highest risk for recurrent dislocation. The next key finding from our research were the most common mechanisms of injury that lead to shoulder dislocation, which were traumatic falls and sports involvement. As mentioned previously, the shoulder is inherently unstable, so it stands to reason that the shoulder would be placed at increased risk for dislocation when a traumatic event occurs, such as a fall. Additionally, if the labrum is damaged from acute damage or chronic damage that occurs over time, this further compromises the stability of the shoulder and increases it for risk of dislocation. Sports involvement often lead to chronic damage to the joint over time due to the repetitive movements, and so this is one reason why participation in sports may put the shoulder at increased risk for dislocation. As mentioned, these were the leading two mechanisms of injury. For males, over 58% occurred due to sports, and for females, just over half of all dislocations occurred due to a traumatic fall. The next key finding were the dislocation characteristics. The directionality was divided into anterior, posterior, or inferior. The directionality was not reported in all cases, but in the cases in which it was, 93.3% occurred anteriorly. For laterality, about 54% occurred in the right shoulder, so pretty evenly split between the right and left shoulder. This aligns with previous research on the topic, specifically with directionality of the dislocation. Because the glenoid is angled superiorly and anteriorly, this provides increased posterior stability for the shoulder. When the shoulder is forced into excessive external rotation and abduction, or there is a force from posterior to anterior on the proximal humerus, It puts the shoulder at risk of dislocation due to that lack of anterior stability to begin with. I would like to point out 3 key takeaways from this research. First of all, the rates of shoulder dislocations have not significantly changed or decreased over the past 19 years. This indicates the need for more effective prevention strategies, especially to prevent a primary shoulder dislocation. This research has identified the most high-risk groups for this injury, so initial prevention strategies can be targeted specifically at those groups. Although programs are lacking that specifically target shoulder stability, one option that could use future research to figure out if it would be effective for preventing shoulder dislocations is the FIFA 11 shoulder program. In previous research, this program has shown success with soccer goalkeepers as well as volleyball players. It primarily focuses on rotator cuff strength, neuromuscular control, agility, and core stability. And so far, it has been shown to prevent shoulder injuries in general and also improve stability. If stability in the shoulder is improved, we would hope that it would also put the person at decreased risk for dislocation. This study has some inherent limitations due to the retrospective study design. It's impossible to determine any follow-up care that the patient received or their long-term results of this injury. There's also lack of detailed information in each patient case, making it impossible to determine why the patient chose to come to the ED for this injury, or if they had access to another healthcare provider at the time of injury, such as an athletic trainer or physician on site. And then finally, we relied on the NICE coding team to enter the information accurately in the database. My hope is that this research will lay the foundation for myself and future researchers to identify effective primary prevention strategies. Again, we want to limit the long-term pain, dysfunction, and decreased quality of life that shoulder dislocations can cause. So preventing the injury before it ever occurs is my goal. I would also like to examine why males are at such higher risk for this injury than females. And finally, consider how the FIFA 11 Plus shoulder program could possibly be adapted or modified to meet the needs of various sports participants as well as other groups who are at risk for this injury. I am happy to answer any questions or provide clarification to anything within this research project. I can be reached at RRodriguez@atsu.edu. Thank you so much for taking the time to learn about my ARP project.